Is COVID-19 herd immunity becoming a myth? New virus variants and the unequal distribution of vaccines are making it more difficult to achieve that goal. So will governments need new strategies to control the pandemic? This is Inside Story. Hello and welcome to the programme. I'm Kim Vinnell. Scientists have long said so-called herd immunity is needed to slow down the spread of COVID-19. That's when 70% or more of the population is protected from the virus, either by becoming infected or by being vaccinated. But some experts now doubt it can be achieved. The head of the UK's Oxford Vaccine Group says that's because of the contagious Delta variant. New infections and deaths are rising steadily in Britain, despite three-quarters of people being fully vaccinated. Andrew Pollard had this warning to MPs.
We know very clearly with the coronavirus that this current variant, the Delta variant, will still infect people who have been vaccinated. And that does mean that anyone who's still unvaccinated at some point will meet the virus. I think we are in a situation here with this current variant where herd immunity is not a possibility because it still infects vaccinated individuals. And I suspect that what the virus will throw up next is a variant which is perhaps even better at transmitting in vaccinated populations. And so that's even more of a reason not to be making a vaccine program around herd immunity.
Other countries with high vaccination rates are also struggling to contain the Delta variant. Israel, where 60% of adults are fully immunised, is reimposing limits on gatherings and restricting indoor venues to those who have been vaccinated. In the US, 70% of adults have received at least one jab, but the pace of vaccination has slowed down. The military, some hospitals and businesses are now making jabs mandatory. And herd immunity is far from being achievable in the developing world. The University of Oxford's Our World in Data says only 1.2% of people in low-income countries have received at least one dose of the vaccine. OK, let's bring in our guests. From New York, we have Wafaa El-Sadr, Professor of Epidemiology and Medicine at Columbia University. In Hong Kong, we have John Nicholls, Clinical Professor in Pathology at the University of Hong Kong. And from Johannesburg, Helen Rees, member of South Africa's Ministerial Advisory Committee for COVID-19 and COVID vaccines. A very warm welcome to you all. Thank you for joining us. I'd like to begin with you, Wafaa El-Sadr. At the start of the pandemic, we were all saying herd immunity. It was the buzzword. That's what we need, herd immunity. Is that done and dusted now? Is the cat out of the bag?
I think we need at this point to really change the discourse and maybe change the narrative around what our goals are. And I think rather than using the term herd immunity, knowing that these vaccines we have, which are really superb vaccines, do not absolutely protect against every single infection, but yet they protect against severe illness, hospitalizations, and deaths. And maybe we should move to using more of a terminology of herd protection rather than herd immunity as much more of a feasible goal for all of us to try to achieve, to ultimately try to expand, scale up vaccination around the world so we can protect as many people around the world as possible from the most severe effects of this virus.
Mr. Nicholls, is that your take as well, that herd immunity is not an achievable goal?
Yes, I agree with what's been said before, and also to pick up on what you also previously said, is that the two ways of achieving the herd immunity were either through natural infection or through the vaccination. I think the experience from Northern Europe last year has shown that basically doing it through the natural infection is not the way to go. It leads to an unacceptable mortality. So vaccination is the way to go. But the problem is that because we're dealing with an RNA virus, not a DNA virus, it's always going to be mutating. And so I don't think we are going to be able to get this level of, in the population, of immunity that we would like to with other DNA vaccines.
Mr. Nicholls, what does that mean for the future, though? I mean, will the virus then be here with us to stay in one form or another for the foreseeable future?
I think if we look at the other RNA viruses which are around worldwide, I think influenza is a good model to use. Because these RNA viruses are always mutating, and you don't get with vaccination a lifelong immunity or protection. So I think we're going to be seeing, like we've seen over the past year, we're going to be seeing variants of the virus evolving, and then we're going to be seeing the fact that the vaccines which we have will not be able to give that complete protection. So I think if you look at the experience with influenza, we've not been able to achieve herd immunity on that. And so we're going to be looking at either annual vaccinations and the recognition that we were going to have to sort of adapt and live with the virus in the community.
On that point, Helen, Rees, I'd like to bring you in. As well as being a member of South Africa's Ministerial Advisory Committee for COVID, you are also a member of the WHO Strategic Advisory Group of experts on the COVID-19 vaccine. So you're very well placed to answer this question. Is the world or global bodies, governments, are they pivoting in the way they should be to this new understanding, this new acceptance that herd immunity is not a goal that we should be looking for?
I think that the answer is yes. I also think that there's a technical definition of herd immunity. And I don't think that's what people are actually asking for. I think what communities are saying and countries are saying is, listen, we want to get back to some sort of normality. We want to protect health. We want to get our socioeconomic situation stabilized and incomes being earned again. But we also want to impact on transmission. And those things are not necessarily the same as achieving herd immunity. So I agree with my colleagues that what we need to do is probably change what we're aiming for. I think we are aiming for a sort of normality. And in order to achieve that, we certainly need to get a vaccine coverage worldwide up much, much higher. And you mentioned the World Health Organization, and the DG of the World Health Organization has set a goal for a 70% vaccination coverage by the middle of 2022. So that's the kind of thing that we probably need to be discussing at the moment. And what would that mean in terms of getting countries and communities back to some sort of normality?
Before we move on, I mean, that goal for the continent of Africa, where I believe just 1.5% of the 1 billion people on the continent have actually been vaccinated, is that even a realistic goal?
Well, the one good thing is that quite a lot of the countries in our region are looking towards both what the COVAX facility, which is going to be providing with vaccines, and also the African Union. And the vaccines are now starting to become available there. So we're very much hoping that in the next 3 months that we're going to see a much larger flow of vaccines into these countries. The bigger question for many countries, however, is that we're trying to introduce a brand new vaccine with a new target group, not children, which is what we normally do, into very weak health services. So the question is, will we be able to absorb those vaccines and distribute them and get them to the first set of populations who are most at risk, and then out to the broader population? So it's going to be a very big challenge. And the third thing is that we have to sustain this. 70% from under 2%, which is where we are, is a huge jump. And that will require a commitment not only from vaccine manufacturers to also prioritize low middle income countries, including our region, but also donors to support the purchasing of these vaccines and support health services so that we can roll them out. Otherwise, we're not going to manage that. And if we don't manage that, we won't be able to. We have a whole continent where we're not able to get vaccination coverage up really significantly. We are not going to be able to break the back of this pandemic.
OK. Ms. Wafaa El-Sadr, I'd like to come back to you. How is it that we've gotten to this point now where we're looking to herd protection rather than herd immunity? Is it a matter of the vaccination rollout just being too slow, the Delta variant coming in? What are the factors that you see that have gotten us to this point?
I think there are several factors, and some of them were touched on by my colleagues on this program. I think it's the nature of the infection itself, as well as the nature of the vaccines we have at hand. And I think what we know is that the vaccines don't provide a full immunity, meaning protect people, the recipient of the vaccine, from getting infected. We know that vaccines are really good at preventing illness and preventing hospitalizations and deaths from COVID-19. So because of the fact that they don't provide full immunity, meaning protection against infection, it makes it very hard to aim for achieving herd immunity. So I think it's an appreciation, a much more realistic appreciation of the nature of the virus itself and its transmission, its high transmissibility, very contagious virus, as well as the challenge with the evolution of new variants and so on, and the nature of the vaccines. We have all of these combined together, give us pause in terms of aiming for herd immunity. I think what we need to focus on is, as Helen mentioned, and as well, is we need to think about how can we use the vaccines we have at hand to be able to protect as many of our population, of the global population as possible, from the severe consequences that can happen from COVID-19. And that means we have to scale up the vaccine availability and distribution and deployment to places around the world where this hasn't happened thus far. There's now a huge disparity that's become very evident where with richer countries, wealthier countries having access to vaccines, while other countries around the world are still at 1 or 2% coverage with these vaccines. And this is just an untenable situation. And it is, I always say, if there's COVID anywhere, there's COVID everywhere. So we have to think in moving forward on how do we protect the global community from the dire consequences of COVID-19 through the use of our vaccines.
Mr. Nicholls, if we're not looking toward herd immunity, we're not looking toward elimination either, are we going to start to see people who are vaccinated getting sicker with the same virus or with new mutations of this virus?
I think the extent to which it comes is that the answer is no. Is that right now, is that those who have been vaccinated, is that they can get actually very mild infection. And I think it's not just infection, but the ability to actually transmit, because these people may be also asymptomatic or have very mild symptoms, which is going to mean that chain of transmission is not going to be broken. But as the two previous speakers have already mentioned, the main function of the vaccination is to actually decrease the mortality and the morbidity. And I think all the data which has been coming across from all parts of the world is that the ICUs and the intensive and the areas of hospital is that it's the unvaccinated who are developing the severe disease. We're getting every now and then, a very small number of cases of moderate disease in the vaccinated. But the main thing of the vaccination is to decrease the mortality and the morbidity to reduce the strain on the healthcare system.
I guess my question, I just want to interrupt you because my question, I mean, the science is obviously very clear. Getting vaccinated, you're much less likely to get very unwell. You're less likely to pass the virus on even. But my question is, if the virus is still going around in the community, even with the vaccinated people, are we going to see new mutations?
The answer is unfortunately a yes, because with these RNA viruses, the more you get a virus replicating, the greater the chance of mutations can be occurring. It's just by the sheer numbers. So if you can actually get those numbers down of either the number of people being infected or the number of severe cases which are producing more virus, then you're going to be reducing that chance for these extra mutations to be coming in. So that's why we've been seeing where there's been high rates of infection, that's where the mutations have been arising. So, and that's sort of the negative feedback, is that what you don't want to have is that if you can keep those mutations coming down, then that means that you don't need to come up every year with a new vaccine. So if you can break down that cycle of more virus being produced, and that's where it's going to be occurring in the regions where there's low vaccine coverage in Africa and also in parts of Asia. So I think the main emphasis, this is why I feel quite strongly about it, is instead of that booster dose, would be to actually have the vaccines where there is a more chance of people getting the primary disease, and so you can actually decrease that potential for more new mutations to come about.
We'll get to booster shots in a moment, but first I want to come back to you, Helen Rees. Should we be investing more in therapies for people who are sick? We have Tamiflu if you've got the flu. What about for people who get COVID but who are vaccinated and might just get it in a mild way? They get somewhat unwell. Is there enough investment, in your opinion, in that side?
No, I don't think there is, and I think that's an excellent point. I mean, one of the reasons that people are individually very frightened of this virus, and as communities we've had to go into lockdowns repeatedly, is because we don't have good treatments. We don't have good treatments yet. We have some treatments, but they're limited for people who are seriously ill and hospitalized. And we don't have good treatments that stop people who've got moderate disease or mild disease progressing to that serious part. And we've got good vaccines, but we could also do with some other interventions in addition to the masks and the social distancing and the ventilation that we're recommending to assist in preventing infection. We haven't invested, I believe, nearly enough in those other therapies. The other problem is that some of the things that have looked very promising, and indeed some of the things that are being evaluated now for treatment of hospitalized patients, are extremely expensive. And so once again, we're getting a secondary effect of access to therapies for rich countries, which simply would not be feasible to be either manufactured or introduced into resource-limited settings. So in addition to investing much more in therapies, we also need to think about what are going to be appropriate therapies to both administer and to afford in resource-limited settings.
Ms. Wafaa El-Sadr, coming back to booster shots, Israel is offering booster shots. The UK is planning to, for the vulnerable, to roll it out alongside the flu jab. Without talking about vaccine equality globally, which is a whole other issue in which we've dedicated a few programs to, but from a science point of view, what difference will boosters make to transmission? Do we have any data?
I think we have some data that do support that for specific populations, specific groups of individuals, a booster dose may be of value. We don't have data that support the booster dose for the general population. So, for example, there are some data that show that for some immunocompromised individuals, these are people with weakened immune system. For example, people who've received organ transplants or people on hemodialysis. So there are some data that tell us that in those individuals, there can be some gains in terms of a boost of their antibodies, of their protective antibodies, after receiving a third dose, after receiving another dose of the same vaccine they've received before. So that's a subset of the population. And I think that's maybe the focus moving forward when we're discussing booster dosing is to really try to think about where we have the data and where the focus should be, rather than thinking broadly of a need for booster doses for the general population overall. And this is based on that, not just based on issues of equity and access globally, but as you said, also based on the scientific data that we have at hand.
Mr. Nicholls, if we're giving up the idea of herd immunity and instead looking towards herd protection, what does this mean for countries like New Zealand that have basically attained elimination? They're going to open up, New Zealand is going to open up to vaccinated travellers from low-risk countries next year. But based on this assumption that we're only going for herd protection as a global community, a country like that is going to have to accept that the virus is going to come in and it's going to infect the population.
Well, I suppose speaking as a New Zealander, you've got a vested interest in that. But I think the reality is that what works well for one country will not work well for another. And, I think if you look at across the water, for Australia seemed to be doing very well. And then you just needed that one case to be brought into New South Wales, and now you've got well over 3,000 people. So even, and the inverse relation is that we have a low, they've dealt well with the COVID in last year, is that the enthusiasm for vaccination is not as high. So, and the vaccination rate is higher in regions and countries which have suffered and which have had major outbreaks. So I think the whole problem is that we found this in many parts of Asia. We did very well, relatively well, in the first part of last year. And so the enthusiasm for taking up the vaccine was not as high as in parts of Europe. And that's a really big problem, is that we're still getting that stubborn 25, 30%. And no matter what the government can do, the advertising, which is saying, basically, we don't want the vaccination. So I think that's going to be the challenge for New Zealand and for those other countries, is that how do you sort of convince that susceptible population? Because those are the ones, you just need that one case and that in that 25, 30%. And also what's also been talked about is of this 70%, I think we're ignoring the fact that the pediatric population, which is the one which if you've got countries which have got 15, 20% of a pediatric population, about the vaccination strategies for them. Because right now what we're seeing is that where the virus is spreading, and this is the data coming out from the Southern Hemisphere, is in the pediatric and the young adult population. That's the group which have not been able to be vaccinated, and then they're spreading it to the parents and then to the grandparents, and it goes forth. And that's what happens in influenza. It's that pediatric population which I think is going to be very challenging to get those numbers up for a sufficient protection.
I think you're very right on the earlier point. It's a very different ball game for those countries that don't have that experience of, everyone knows somebody who's had COVID or has had COVID themselves or has seen their local hospital overwhelmed. Very different for countries that haven't had that. I'd like to come back to you on that front, Helen Rees. What is the best incentive for people to get vaccinated from a public policy point of view? What do we know works to get people out and to get those jabs?
Well, I think there's several things. One is that, and I think everyone's familiar with the anti-vax expression now. That's a minority, a small minority. And those people existed before COVID and they will exist after COVID. They don't like vaccines and have many reasons that are given for that. But the majority of those sort of 30% that we've just mentioned are people who are nervous or people who don't see themselves at risk. I mean, many young people in the 20s don't necessarily see themselves at risk, and they're saying, well, if I get it, I'm not particularly sick and I'll have antibodies, so why? So it's that group, those who are nervous, and many of the reasons are things like, have we developed the vaccines too quickly? And so we have to be able to explain about things like compressing the timeline for vaccine development and monitoring for vaccine safety. And people who want to see the vaccines rolled out to other people first to see how does it go for them before they will take it. So I think the first thing we have to do, and you've got scientists here with you, is do a better job from the science perspective and the public health perspective at persuading those people in that category to have the confidence to come forward. The second thing is that, it is the sort of carrot and stick, and we're beginning to see this in a number of countries. We've seen it in France, for example, saying, if you want to do this, because there's a risk if you're not vaccinated, you really will need to have a vaccine if you want to go into a restaurant, if you want to go into a nightclub. So that's the sort of, it's both the carrot and the stick, if you like. And I think we're going to see more and more of those kind of incentives. But the incentives, in a way, are also the stick, because if you don't do it, you won't be able to do certain things.
Yeah.
And the third thing that's obviously under wide discussion is whether for some jobs, for example, it needs to be compulsory. We've seen in Kenya a discussion about public servants. We've seen in other countries discussion about healthcare workers. So if you're in a job in a frail care, old age home environment, do you have a responsibility, and does government have a responsibility to ensure that you're vaccinated so that you don't...
I think countries around the world are grappling with exactly that. Hey, we're going to have to leave it there for time. Thank you very much to all of our guests, Wafaa, El-Sadr, John Nicholls and Helen Rees. And thank you too for watching. You can see the programme again anytime by visiting our website, aljazeera.com. And for further discussion, go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. Our handle is @AJ Inside Story. From me, Vinnell, and the whole team here in Doha. Bye-bye for now.